Welcome back to Ohio Counseling Conversations, the official podcast of the Ohio Counseling Association, bringing you updates and conversations from around the state. This month, we have Dr. Matt Fullen and a conversation with me, Kaylee Bradley. On today's episode, Dr. Matt Fullen will discuss Medicare advocacy, working with older adults, and his experience with both. I always kind of like to start these conversations with just having you maybe share a little bit about yourself and kind of, just in general strokes, the work that you do.
Sure, I'm happy to, and thank you so much for having me on. I'm really excited to spend some time talking with you. So my name is Matthew Fullen. I'm an associate professor at Virginia Tech in our counselor education program. Been here 7 years, and I've gotten to do a lot of exciting work around helping the counseling profession navigate Medicare reimbursement, how to work with older populations of people, both clinically and teaching and supervising students through that. I'm excited to spend some time just chatting about sort of these mutual interests that we have.
Yeah, wonderful. So Ohio Counseling Conversations, we're the official podcast of OCA, the Ohio Counseling Association. I was hoping maybe you can share a little bit about your connection to Ohio as we get started with our conversation here.
Absolutely. So I am a Buckeye at heart. I grew up in central Ohio in the Hilliard, which is a suburb of Columbus. Was born there, went through all of K-12 school there. And then actually after college, moved back to central Ohio, worked for a nonprofit organization that focuses on low-income housing for older adults in Columbus. And that's sort of part of my older adult interest story that I'm sure we'll get into later. Did my master's degree in clinical counseling at Ashland Theological Seminary, and then completed my PhD in counselor education at Ohio State. So a lot of wonderful memories of living in Ohio, working in Ohio. Still have a lot of family in Ohio, and so very much have connections there. And my clinical license, I'm an LPCC in Ohio, and I maintain that license regularly. I also was very involved with OCA particularly when I was in my doctoral program, and was actually chair of OCA's Government Relations Committee for about a year, 2016 to 2017. And was on that government relations committee prior to that as well. And really that's where a lot of my work on Medicare advocacy really started to come together. So, a lot of wonderful recollections to OCA and to all the wonderful work that you all do.
Oh, awesome. Well, I want to kind of, start digging into this conversation, Dr. Fullen. I know you hinted at kind of a focus and specialization on counseling older adults. What drew you, I guess, to that particular demographic? What were some of the needs that you kind of saw that maybe weren't kind of being attended to?
Yeah, so as I've reflected back, I've really been able to kind of focus on the fact that, first of all, had really close connections with grandparents growing up. And I think that centered an interest on people who were sort of that generation, 2 generations beyond my own. There was a just kind of a deep sense of affinity and respect and admiration for people that had been through life and were able to navigate certain things that maybe I was struggling with. Really felt like I could go to those grandparents and get some degree of wisdom and perspective from them. And so I think on sort of a subconscious level, there was that openness to working with older people. I mentioned working for a nonprofit right out of college that focused on low-income housing for older adults. And working with that company, I really had a lot of direct exposure to older people who were navigating challenging transitions in their lives. Some of the work that was happening within that organization was renovating these senior living communities, really taking them from some of these places had been built in the 50s and 60s, and really trying to modernize them and make them as livable as possible for the future. And I had the task of getting to know some of these individuals that we would have to relocate from one unit to another. And as you can imagine, many people had mixed feelings about this. They were excited about some of the renovations that were going to happen, but they were also very partial to that exact unit that they were had a history of living in. And so it was this opportunity to have kind of these crucial conversations with older people who are in transition. As I then navigated graduate school in a counseling degree, sort of went through that program as more of a generalist, but always had a sense of expectancy and excitement when I had those clients who were further along in the lifespan. Always found their stories really interesting, and felt like I had something that sort of excited me about being able to hear their stories. I also quickly learned through that experience that not every counseling graduate student had shared that interest, and so that became a way to sort of differentiate what felt very normal and natural to me about working with people in that generation wasn't necessarily something that every graduate student shared, and that was illuminating to me. It wasn't something that I necessarily had fully appreciated until I was in that context and could say, hey, maybe there's something special about this interest that I need to pay attention to. My first professional position as a licensed counselor was within long-term care facilities in North Central Ohio. And I was asked to provide counseling services to older people who were navigating a lot of these challenges with medical issues, with other transitions to their living situation. And again, just really found that this was something that was energizing, and I enjoyed being able to give them a chance to share their stories, especially as I continued to learn that mental health services were not particularly, were not offered very frequently within those settings. And so that sort of shifted into a place of then like advocacy and really wanting to make sure that we had more access opportunities for people who are navigating some of those challenges in life. And all of that then ultimately led to just a deep and committed sense of wanting to help the counseling profession better understand the needs of older adults, in a transition into doctoral studies, and really thinking about, where is the focus on aging within the counseling profession, within our scholarly literature, where it was largely lacking, within our kind of professional conversations, where there was talk about Medicare going way back into the early to mid 2000s, but not always a lot of momentum around that issue. And so all of those different pieces converged and really became a strong sense of calling for me professionally to make older adulthood the time in the lifespan that I wanted to really put on the counseling profession's radar and make sure that we were mobilizing our skills and resources as counselors to help people at that phase of their lives.
Yeah, such good stuff. No, I'm looking kind of at our questions, Dr. Fullen, and I think there's so many directions that we could take this conversation. But I do kind of want to make sure we zero in on this Medicare reimbursement topic, because I think it is so crucial and important. It's long been an advocacy initiative within our field. Walk our listeners maybe through, just what that advocacy journey has been, as we finally, and, here in 2024, are at the very early stages of being able to be Medicare providers as counselors. I would love to just hear a little bit about that advocacy history, if you don't mind.
Absolutely. So at the profession level, there's been advocacy related to Medicare reimbursement for counselors that goes back 25 plus years. And if you think about this historically, so 1989 is when Congress had last added new mental health providers to the mental health or to the Medicare program. So in 1989, Congress passed legislation that incorporated licensed clinical social workers and removed some restrictions around psychologists working within Medicare. In 1989, the counseling profession was still really in a process of creating that distinct professional identity and pursuing licensure. We didn't have licensure in all 50 states until over a decade beyond that point. So even in 1989, as Congress was adding mental health providers to the Medicare ranks, the counseling profession was still really emergent. And it wasn't then until sometime later that the counseling profession, as it became more solidified, started to do that sort of federal advocacy and said, hey, Congress, what about us? We need to be a part of this Medicare solution as well. The last 25 years of that advocacy, there's really been ups and downs along the way. Congress, over that 25-year period, there have been certain challenges where Congress has a harder time maybe coming to a shared conclusion about passing legislation. There haven't been any other updates to the Medicare mental health regs in terms of who can be an adequate provider. And so there really was sort of this period of maybe professional wandering. We wanted to be a part of it. We were doing advocacy to be a part of it, but there really wasn't that sort of convergence of all the different forces that go into making legislation happen. I began really getting involved with Medicare reimbursement in right around 2013 and 2014. What happened for me professionally was actually within that work in long-term care settings. I had clients who were on Medicaid, and that's how I was able to work with them as an Ohio LPC. But I also had some clients who were Medicare primary or who had certain circumstances that shifted their reimbursement to Medicare as opposed to Medicaid. And one client in particular really represented to me professionally just how important that Medicare work was going to be. So this was a client I had worked with for over a year, and this client had made major strides in her life around depression and anxiety management. Counseling was really working. And then I remember to this day getting a call from my boss at the community mental health agency. And the message left on my voicemail was, Matt, you can no longer work with this client. When I called to find out why, the supervisor explained that this client had actually been transitioned into qualifying for the hospice program. And because hospice was and is a Medicare benefit, all of the work that we had done through Medicaid was no longer allowable because this person was Medicare primary. And my supervisor said, she can still get services, they just can't be from you, and they can't be from any other licensed counselor. So that sort of event really sparked just a deep sense of injustice for me around how this insurance process was not working for clients. And it really got me, really motivated me to dig in and to better understand the counseling profession's Medicare advocacy history, where we had been, where we were, where we wanted to go. And it also inspired me to dig into the counseling profession's literature on working with older adults, exposed me to a lot of great work historically done by Dr. Jane Myers at the University of North Carolina, Greensboro, and Ohio University prior to that, but also revealed that in more recent times, there really hadn't been a lot published on working with older adults. And, the common thread for maybe why that was the case was a lack of Medicare reimbursement. Without that central piece, so many older people who rely on Medicare would not be able to have access to counselors. And so those sorts of experiences really solidified that deep sense of, I want to fully understand what our profession's history has been and how we can continue to do better and better advocacy to make this change a reality. And, because clients like the one that I had previously served deserve to have the same access as everyone else. Kaylee, I know your connection to end of life care and to grief, and I mean to hear that a person, because of transitioning into the hospice program, would actually have less access to services. It was completely counterintuitive. Not how the Medicare program intended to provide services, but because of that lack of providers, it really was creating a barrier that needed attention. And so that led to then, the last decade or so of advocacy, where I think the counseling profession, there's really been a lot of exciting developments, all of which then led to the law change at the end of 2022, which went into effect January 2024. And I'd be happy to talk more about sort of the last phase of advocacy, because I think there's some really exciting things that counselors and counseling leaders have been involved with, and it creates somewhat of a blueprint for how we can make social change happen with other issues as well.
Yeah, I think this is all so important. Yeah, and I would love to kind of focus now a little bit on where we're at currently. I know, we are, as you've indicated, we've made some really great strides and progress. What do you kind of see as the barriers still kind of inherent for maybe older adults who are wanting to access or seeking mental health care? There's a couple of questions that our committee jotted down about ageism, certainly a big barrier, but what do you see kind of in the current landscape for older folks seeking care?
Yeah. Well, there's a number of things. So, we have to be mindful of sort of the systematic exclusion of a big chunk of the mental health workforce, aka licensed counselors and licensed marriage and family therapists. That is now changed in the law, which is a massive step forward, but it will take some time for the professional opportunities to really kind of catch up with this historical exclusion. So what I mean by that is that counselors who had been excluded from the Medicare program now have to take steps to enroll in that program, to navigate becoming a approved provider via Medicare, and that's going to take some time. When that approval happens, they also then have to make sure that they're marketing their services to Medicare recipients. And that may require a shift in some of the ways that they think about, who they serve, which client populations they're most accustomed to working with, things of that nature. So when we think of barriers to mental health services and psychotherapy services for older adults, there's a number of different ways that we can go with that. So one is on the provider side. We know that historically and to this day, many healthcare providers and mental health providers have their own biases about older adulthood and about whether older people benefit from mental health services. Some of that stigma goes all the way back to Freud and early 20th century understandings of human development. Freud thought about the lifespan development. Most of the good stuff was happening in the first 40 years of life, and beyond that point, sort of a slow waiting for death and demise. We know that that's not actually how aging works. We know that older people, by and large, have very positive experiences of life, have high degrees of life satisfaction, higher in many ways than people at other phases of life. And yet there is that sort of lingering assumption on the side of the providers that, older people might be depressed just because they're old. That sort of myth is going to interfere with one's expectations about providing services. We also know that many providers have not had a lot of training in how to work with older people, and they may assume that, what I was trained how to do with other populations somehow doesn't apply to working with older adults. That's largely not true, and yet it can be the sort of professional barrier that keeps providers from proactively marketing their services to older people. So that's on the mental health provider side of things. On the client side of things, there is some reason to believe that some older adults carry stigma around mental health care. I would add that that's the case across populations as well. That's not just older people, although there may be a preponderance of older people who grew up at a time when mental health services were not nearly as ubiquitous, or those mental health services were associated with hospitalization or more severe psychiatric illnesses, as opposed to mental health being something that is more broadly helpful for a lot of people. And so if older adults have some of those biases, then of course we have to help kind of work through that with them. Not only once they're in our counseling office, or once we're working with them in a senior living community or something like that, but we have to work with that bias upstream as well. Think about, public messaging from a health department around mental health is health. We typically see those messages, and then we will see a child or a young adult's picture associated with that. So from a public health and sort of a communication standpoint, there's work that has to be done to send the message to older people that mental health care is a normal part of your health care as well, and that we have a workforce that's now ready to help you. So being able to kind of bridge that is going to take some time, and it's going to require counselors in the counseling profession to be proactive about that. Sometimes counselors think about their work as having this really beautiful office and waiting for the clients to show up. And with older populations, just as with other populations that have been historically marginalized from mental health care, we have to think of ways to take the services to the people and not just wait for the people to arrive at our door. And so with older people, that can look like building partnerships with an assisted living community, a retirement community that's based on age, a long-term care setting. It can look like being proactive with building referrals with primary care providers, where many older people are more likely to first report some sort of mental health concern. If their doctor or nurse practitioner can hear that and understand that might be depression talking, that might be anxiety talking, and then pick up the phone and make a referral to a local professional counselor, then that really does break down some of those barriers. But there's a lot of work that has to be done to make all of that a reality.
But such good suggestions I think you're offering, and I'll be transparent. I have a private practice, and we're in the midst of becoming Medicare providers, and we're trying to have some of these conversations that you are guiding us, and I think so well. What might services look like for this demographic, and inviting us to kind of maybe shift a little bit as you're sharing what counseling maybe has typically looked like, and making sure that we're accessible to this demographic. Which kind of leads me, I think, really nicely into this question. What would you maybe say to a younger counselor or a new counselor who maybe is interested, right, in working with this demographic, but maybe feels like I'm maybe unqualified? I guess what encouragement or affirmation might you give to, early professionals who are interested in this work?
It's a great question. I work in a counselor education program. I have this sort of conversation with many of my students. Not every graduate student has an interest, at least not at the outset, of working with older clients. And I would say that many students that I've worked with, it's not just older adults, aka people 65 and up. It's really anyone beyond the point in the lifespan where that student feels like they themselves have traversed. And that's something that has led to some good conversation in our classes. Typically, this comes out in maybe a lifespan development class or another, maybe a counseling diverse populations class, where we can talk about what is it about working with other people like ourselves that feels so much more comforting when we're in the early phases of counselor development? And how do we make sure that we don't stay there? Because whether it's age or whether it's a different social identity demographic, counselors are expected and really urged to get out of their comfort zones and to think about ways to serve people who are different than them. We teach students who are, a little bit reserved or has reservations about serving older adults. I try to encourage them by thinking about it the same way that they might think about someone else who has part of their life story that is not in that counseling student's direct experience. So we rely on giving the kind of the storytelling power to the client. We default to the client's expertise on their own lives. We don't have to kind of give voice to that imposter syndrome within that tells us, you don't know what it's like to experience XYZ, therefore, what help are you going to be able to provide? And so we really encourage students to think about this as just another way to use those core counseling skills: active listening, reflecting, summarizing, and most of all, empathy, to understand that, there are things about your story that I don't directly have access to because of my own experiences and limited experiences, but I can hear you telling me that this felt incredibly difficult, or this feels incredibly exciting, or I hear you telling me that, this is something that you never thought you would have to go through, and yet here you are now. Tell me more about that. A lot of those just sort of curiosity questions and inviting the client to tell their story and to externally process some of the things that they may be struggling with. Those are core skills that we can apply with older people, just like you would apply with other people that might be different. One other direct skill that we try to give voice to is broaching, but in the context of age differences or generational differences. So we tend to think about broaching with race, ethnicity, religion, sexual orientation, but we can also do that when it comes to age. And so if I have a client, or if I have a client who is 30, 40, 50, 60 years beyond where I am in the lifespan, it is appropriate to bring that up, to name that, but to name it in a way that really respects the courage of the client to still come to counseling, and to say, I recognize that we are in different stages of the lifespan. And there may be things about your age and my age and the differences and when we came of age, when we grew up, that shift some of our assumptions about what it means to be human. I just wanted to name that, bring that into the counseling conversation, and to know that, and to let you know, client, that if that ever feels like something off-putting or concerning, I want you to be, it's okay for you to put words to that. And by doing that, it sort of takes some of the power, or some of the perceived limitations of what I can do as a counselor. It kind of, takes that away and allows me just to focus on that human connection that we would really encourage students to lean into, regardless of who they're serving.
Yeah, such good stuff. I always encourage my supervisees as a supervisor, like, don't underestimate the power of your presence, right? And as you're speaking to, just that empathy and positive regard. Yeah, absolutely. So we just have a few more questions here. I know there's so much more we could dig into, but how do you define advocacy? That's been a theme throughout this conversation this morning. I'm just curious what suggestions maybe you have for folks who just are considering, yeah, what does it look like to engage in advocacy work kind of generally?
Yeah, I would say that there is this deep kind of well of advocacy that the counseling profession has leaned on over the course of its history, and that sort of spirit of being advocates, whether that's on behalf of our clients or our communities or our students, or in some cases, in the face of legislative or kind of policy change needs. that sort of advocacy is really powerful. And I encourage people, regardless of what the particular population need or particular issue might be, to lean into that spirit of advocacy and to look for like-minded people within the counseling profession or outside of it who can really kind of have your back as you're trying to navigate some of these big issues. I know that for me, around the Medicare issue in particular, in the early phases of getting involved with that, it was just a lot of trying to explore what was happening, what was going on in the broader advocacy efforts. I kind of on a lark, attended a conference that the Association for Adult Development and Aging was putting together. I think this was in about 2014 in Washington, D.C. And I knew that a part of that conference was going to be spending a day on Capitol Hill. And I thought, what better way just to find out what that's all about and how I can get involved. And maybe that's a way that I can share some of my, at the time, clinical experiences around the Medicare issue interfering with client care. And through that, just kind of taking that leap, and I didn't know a lot of people who were going to be at that meeting, but I went and just decided to give it a shot. I ended up through that conference and through that day on the Hill, getting to know Vicki Kress from Youngstown State, who had been and continues to be a great champion for counseling and for Medicare reimbursement. And we began to then get to know each other and to have sort of a shared interest in Medicare reimbursement advocacy. That also gave me an opportunity to get to know other counselors who either had a deep commitment to older adulthood and wanting to change Medicare for that purpose, or counselors who were deeply committed in some other issue, but were willing to join the team when it came to Medicare reimbursement because they knew it was really important to the counseling profession. So I think just taking those risks to get involved and to look for other people is a really important starting point. And then as you get more opportunities, especially if there's a particular area of expertise that you hope to develop or a topic that you're really passionate about, to invest yourself fully in understanding, what is the history on this issue? How has the counseling profession engaged it? How has the state I live in or the country I live in engaged this issue? And really become well-versed in the nuances of this so that you can use those nuanced understandings when you're given the opportunity. So for me, with Medicare, it was becoming a student of the Medicare program, really understanding how the Medicare program itself had come into being. One of my very first publications was as a doc student writing about Medicare advocacy, and publishing it in the journal that the Association for Adult Development and Aging puts out. And it gave me an opportunity just to really understand, how does Medicare work? And then how should that inform what counselors have to say about Medicare? And over time and through that sort of deep dive process, really began to understand some of the key ways of talking about this that seemed to sort of shift the narrative on Capitol Hill. One of those that I'll share, just because I think it has application across a lot of issues. When we first started advocating back in the mid 2010s, so like 2014 to 2016, 17, a lot of the focus in how this was being talked about was telling Congress, it's not fair that counselors can't be involved the same way that social workers and psychologists can. We have similar training, we have similar educational background. Why can't we be on, at the table as well? That was really talking about it with the counseling profession centered. What we eventually learned was that was overlooking the client voice and overlooking the Medicare beneficiary voice, and really making it more about the profession's wants, as opposed to shifting the narrative to say, Congress, you realize that there are 60 million Medicare beneficiaries. That number is only going to go up. Their mental health needs are only going to go up. And you don't have the workforce to meet that demand. Meanwhile, we have 40% of the workforce sidelined because you have a policy or a law that hasn't been updated in 35 years. How can we help you solve this problem that is rampant within your communities using the skills and the education and the training that we have? So that shift really was a shift from focusing on ourselves to focusing on the people that we serve. And I think that was one of several just key, key inflection points that really changed how Congress heard the message and how Congress then became advocates alongside us to get something done. And I guess that would be my third just takeaway is that when you're doing legislative advocacy, whether that's local, state, or federal, keep in mind that the people that are elected to make these decisions ultimately do have something in them that really makes them faithful to their constituencies. I know that sometimes that gets lost in all of the ways that politics and sort of the talking heads operate. But look for that humanity within the lawmaker as well, that part of them that says, I have an older adult family member who's on Medicare, and if they ever needed depression treatment, gosh, I wouldn't want them to have to wait 6 months when there's people available next week. You bring a good, that's a good point, counseling profession. Maybe we can do something about that. So I think being able to aggregate those sorts of to get the lawmakers to advocate alongside you, and you really have to have good data, good numbers, good stories, good client anecdotes, as well as good research to be able to help the lawmaker understand, yeah, this is really something that I want to get behind as well.
Yeah, I think, no, that's such an important point. And I do want to make sure, if you want to touch on Dr. Fullen, any kind of more recent advocacy, but I think you did a beautiful job of, encouraging us all to kind of see the humanity, right, in one another. You've mentioned stories a lot, and I think that also, my goodness, really speaks to our commonness, right? So I want to, we have one question that we kind of end our conversations with for all of our guests, and then I'll definitely invite you if there's anything else that we missed. But the name of our podcast is Ohio Counseling Conversations. So we like to ask all of our guests, what important conversations do you think counseling professionals right now should be having with each other and or their clients? So what should we be talking about as counseling professionals?
Well, I will have to sort of revert to where my kind of focus and expertise lies, and so I would encourage Ohio counselors and counseling professionals to continue asking themselves, now that we have been approved as Medicare providers, and now that we do have an opportunity to serve a growing number of older adults who live in our communities, what is the implication for me? And that implication might be a clinical one. It might mean I need to look into enrolling to be a Medicare provider. I need to look into ways that I can use my clinical practice to support the needs of that population. Or it might look like, if that's not for you, it might look like, how can I help other professionals in my network better position themselves to serving that population? So if that's not something that you directly plan to do for any number of reasons, it could be that you become a champion referral provider to those counselors in your network who really are gearing themselves up to work with that population. If you're a counselor educator, it's thinking really critically about, what does this mean for the way that we cover diversity within our courses, the way that we cover the lifespan within our courses? The 2024 CACREP Standards have some really targeted but sort of subtle shifts in how they define social and cultural diversity. And they highlight age and generational status as parts of that definition. If you didn't really tune in, you might miss it. And yet that is a change in 2024 that counselor training programs need to really reflect on, not just to be in conformity to the standard, but also to think about, we have students who will be serving an increasingly diverse population, and that includes age diversity. And we can no longer point to the lack of Medicare reimbursement as sort of the explanation or excuse for why we're not doing more. That day, that ship has sailed. And so now it really is back on us as a profession. What will we do to try to make the services that we provide more accessible to the 60 million plus people who rely on Medicare, both older adults and younger people with long-term disabilities that rely on Medicare?
Well, we can't thank you enough, Dr. Fullen, for spending time with us this morning. Before we kind of log off here, anything that we missed that you want to make sure that we cover? Any resources that you think are helpful? We'll give you a few minutes here to, maybe tie this in a bow for us. But do we miss anything?
Well, since we've had such an opportunity to talk about advocacy, I do just want to encourage the listeners to, to get involved in advocacy in every sense of the word, and to not fall for that trap of, what could I possibly have to offer, or to think that, somebody else is taking care of that need. That's not for me. Counselors and counseling professionals, we make up the profession. The profession isn't anything above and beyond the people that comprise it. And so, as every individual provider, as every individual OCA member is thinking about what they can do and how they can do more in an advocacy sense, that really is what gets things done. So when you think about big changes within the counseling profession over the last 10 years, Medicare just being one example of that, these changes happened because of the concerted efforts of individual counselors, associations, both state and national, and, just people being willing to sort of get their hands dirty when it comes to advocacy, and to dig in and to look for communities of other like-minded people to do that with. So just a note of encouragement as everyone is thinking about all the busy work that they're doing, to not lose sight of those opportunities to contribute, when there is a call for advocacy locally at the state level or at the federal level.
Well, again, I think that's such good insight and advice. And OCA Legislative Advocacy Day is coming up in April, so this is a good time to have this conversation and just that reminder. I love what you said earlier, kind of leaning in to that spirit of advocacy. Well, Dr. Fullen, thank you so much for being with us. This has been Ohio Counseling Conversations. Thank you so much.
Thank you, Kaylee.
Ohio Counseling Conversations is on a mission to make this podcast meaningful to you, and we can't do that without your help. A feedback form is linked in the show notes for this episode and is also available on the OCA Linktree. If you have any recommendations for topics or guests or any other general feedback, you can let us know by using the form. We welcome your thoughts so that we can continue to develop the podcast and grow as creators. If you are interested in joining the team or being a guest, you can also reach us by emailing ohiocounselingconversations@gmail.com. We value your insight. Thank you so much for listening.
If you enjoyed this episode, please make sure to follow us so you can stay up to date with Ohio Counseling Conversations online and wherever you listen to podcasts.
This podcast is brought to you by the Ohio Counseling Association's Media, Public Relations, and Membership Committee and its podcast subcommittee. This podcast features original music selections by Elijah Sototer-Wood and our closing song, Accretion Discotheque by Who AD. Views, beliefs, or references mentioned in this episode do not constitute an endorsement or recommendation by the Ohio Counseling Association. The views expressed by guests are their own, and their appearance on the podcast does not imply an endorsement of them or any entity they represent. Views and opinions expressed by guests do not necessarily reflect the view of the Ohio Counseling Association or any of its officials. Thank you.